everyone. Welcome to our morning session today. Thank you for joining us bright and early. We're happy to have you on board. We have a great panel here today for everyone to ask questions in a bit here. But in the meantime, we're going to go through a small presentation first. My name is Kevin. And I will be the host today for this particular session. So what we're going to do right now is I'm going to go through my slides here first. So let's see. Perfect. So a lot of you may be interested in learning a little bit more about our Fqac lookalike status. We've gotten a lot of inquiries from various folks on the line here. And I will be going into a little bit of an intro first, and then we're going to go into the roundtable where you're going to have an opportunity to ask some questions. When we first looked at the Fqac program, it's going back more than 3 years now. And Dr. K decided that that would be the path the Medical Foundation would take. And certainly it was after 3.5 years of hard work and preparations that we're able to now be designated. And when we talk about the designation, one of the top questions that we get is, what is a lookalike? A lot of times we talk about Fqac. What's an Fqac lookalike? So I'll be going through that a little bit here in the morning. I'm going to talk about the needs assessment that identifies if your area will have a need for an Fqac or an Fqac lookalike clinic. And then we're going to go into more in-depth as to how the Fqac lookalike program has affected or influenced the Medical Foundation's operations. So when we look at the Fqac and the lookalike program, this is essentially the difference. Under a fully designated health center, you can see here one of the major things is having coverage under Tort Claims Act, having federal loan guarantees for capital improvements. Those are things that you don't really see as a lookalike. Now, what's interesting is since those are the major differences, what has actually happened during the pandemic, or I should say just post-pandemic world, is that some of those things are being extended to lookalikes as well, because now there is an increasing recognition that lookalikes do pretty much everything an Fqac does, except that there are a lot of lookalikes. There are also a lot of FQs. And to open up what we call access point applications, they actually take time and takes a different form of evaluation as well. So, for example, even though we don't qualify for federal grants as a lookalike under Section 330, one of the things that's been changing during the pandemic, or I should say post-pandemic more or less, are some of the grants are being made available for lookalikes as well. Even though they're not as high of an amount, what's happened is that there are some subsidies, sometimes in the amount about 50%, let's say, that would apply to lookalikes as it would for FQs. So it has been an interesting development in the post-pandemic world. How this would transform will really depend on the budgets available for the government and also depend on the kind of services the Fqhcs or lookalikes will continue to provide. Keep in mind, around the whole country today, there's about 105 lookalikes, plus minus. And those figures are still quite substantial. So lookalikes have been really pushing for some of these areas to be extended to lookalikes as well, such as capital improvements. So those will be interesting developments that we continue to see in the post-pandemic world. And when we talk about the need, it is interesting to firstly understand how the whole healthcare system currently breaks down to. Fqhcs are established in the areas that are considered to have the need for that particular service. And when we look at the entire market itself, as this slide would show, is the whole population right now is about 330 or so in population. And when we look at how it breaks down, you can see that it breaks down to 3 main categories. And these categories essentially show how the population currently look. So we have Medicare being one major areas for people age 65 and above. And then those that are below age 65 and non-military, you can see that that's the majority of the population. And the breakdown of those translates to about 159 being covered by employer base. So employer base would be plans, for example, that Tzu Chi would offer its employees for as an example. And then other coverage is where it breaks down to the different Medicaid programs. So for us to really be able to make use of that other coverage portion, at least for some of those areas, you can see very clearly here that you have to have a need before the government grants you the designation. So what is actually a need? So if we look at our LA County region here today, this is part of our application to getting our federal designation. You will see where the plus signs are, that's where our clinics are located. And the colors, the red pieces, show that the poverty rates are actually a lot higher. So where we actually operate, we're in regions where poverty levels are actually high. Those will be poverty levels about 20% or higher. Now, does that actually mean one way or another that you'll be designated for sure? No, of course not. There are a lot of factors that go into the designation, but poverty levels is one of the most important, because what we're really talking about here are federal or state-based assistance programs, which Fqhcs are really geared up to target. That's why for our reimbursements for the fees, or I should say costs of delivering healthcare, is exactly why we want to operate in these areas. As you can see, the opportunity to continue to grow and to continue to serve more people, it's certainly there. In fact, there are a lot of areas outside of our current service territory that you can tell has additional needs as well. So this chart illustrates even better as to where things are at. So if we look at the federal poverty guidelines, now keep in mind the federal poverty guidelines are actually quite low. For one person, we determine it based on family size, we determine based on income. The actual minimum wage, if you have a minimum wage job, that would essentially put you over the 200% federal poverty guidelines. So being within the 100% means that you're not really working full-time at all. So there are people that can't, there are people that are struggling as well to find a position that would pay even minimum wage. So in the territories that we actually service right now, based on our permanent clinics, you can tell below 100% means that they're not actually making that $10,000-ish for a person, one household family. You're looking at about 310,000 people, and which means that our service percentage as a percentage of the total population is about 14%. In the whole LA County, the average is actually about 17%. So you can see that there's actually a lot of poverty in the areas that we currently serve right now, as well as areas that we currently don't serve. So the opportunity certainly is there, and there's a need for this type of healthcare providing setting, which the Fqhcs certainly cater to. And this particular chart here tells you a little bit of breakdown as to what kind of salary, what kind of income there are in the current areas. So combined with these factors is where the assessment, the need assessment really happens. Now, when we look at expanding across the US or even across California, these will be key statistics that we need to examine to ensure that we're putting locations where there is an obvious need for an Fqhc or Fqac lookalike center. Now, in addition to just income, poverty rates, as well as household size, there are a lot of metrics that prompt the needs as well. And if we look at a combination of those needs, which is based on income as well as their health status, you can tell here that a lot of distribution, let's put it that way, that low income numbers and fair and poor health status is actually about 25.8% in the areas that we currently serve. So it is certainly higher in where we are right now than the LA County average or even California average. So when we look at those that assess their own health conditions as fair or poor, with amongst low income earners, that is a large percentage. Now, aside from just the cross-section between health and income, there is also an importance that we need to determine, which is the kind of diseases or chronic illnesses that people may have. And these precise measures are the measures that government wants or HRSA wants health centers to focus on. There are 18 measures. Now, I'm not going to be able to go through all 18 measures, but certainly want you to be aware as to where these measures are. So if we look at, for example, heart disease and hypertension, our percentages are actually quite high as well compared to the county as well as the state itself. So we look at ever diagnosed. This is someone a patient that's ever been diagnosed with heart failure, congestive heart failure. In where we are right now, there's about 34,000. That's among low-income earners. Keep in mind, this program, because we service mostly state-based, in California's case, Medi-Cal, that coverage is only up to a certain percentage of the federal poverty guidelines. That's why a lot of the references are towards low-income earners. So those that's ever been diagnosed with high blood pressure, per se, in our service area, there's actually about 319,000 of them, which accounts for 32% of low-income earners. So these are stats that one would need to evaluate to see where we are. Our service territories, are they suitable for a health center? So this is based on heart disease and hypertension. There's tobacco use, which is, again, one of the 18 measures that health centers need to try to improve once they acquire these patients in the local areas. There's also obesity being a really important area. And as you can see, a lot of people are actually 18 or older and obese in the low-income population. And that accounts for 2/3, actually, of the low-income earners. Cultural sensitivity also being an important one. One of the advantages, obviously, with Tzu Chi, especially with our health centers right now, is that we're able to deliver healthcare in 3 different languages. For example, we have Chinese, we have English, obviously, as well as Spanish. So in the preparation work of this, you can tell, not aside from understanding needs, we have to determine what do we do to accommodate these patients that are of low income. So one of the things that we do is something called a sliding fee scale. A sliding fee scale is something that you have to implement as a health center. When I mentioned income being low, let's take a look at the very left column here. It says at or below 100%. So at or below 100% for a family size of 1 person, meaning that this person doesn't have any other dependents, for example, you're looking at an annual income no higher than $12,880. That is a very low income. If you made the minimum wage in California right now, in fact, you would be well over the 200% threshold, which means that you would actually not even qualify for the sliding fee scale. So as you can see, the catering of the patient group here is specific to low-income earners, especially if their family size is anything more than 1 as well. So in the preparation of this, there's actually a lot of work. The entire team was mobilized. As you can see on the picture here, there's study groups that we formed involving most of our staff members. We're very happy that we have great volunteers that helped us out as well to prepare for the different it's almost like examinations, for lack of better words, for HRSA to come and inspect what we have prepared and if we're ready as a health center. So not only are we involved as staff members, our board members are very involved as well. And you can see here our board members are having study sessions as well as an interview actually over lunchtime that HRSA conducts. So that is the amount of preparation work that went in just even for that one 3-day visit. So talking about the 3-day visit, a lot of you may know the current team very well, but one person you may not know very well is our CFO, John Panzerande. He came to us with more than 20 years of experience and was a crucial part of getting our designation as well. So let's watch a brief video of not only what our health centers are doing, but as part of that, also pushing vegetarianism.
Hello, hi, my name is John Azurande. Hello, Master Chen. I've been involved with Tzu Chi now for about 3 months. It is truly an amazing organization. I came here to help out with the fiscal, with the finances, so we can pass the site visit. I've been with Tzu Chi like for about 4 or 5 months. I work with other health centers for about 10 of them. This is truly an amazing organization. I've learned about vegetarian meals. I've learned about spirituality. I've learned about kindness. Great organization, and the service you do to the community is just amazing. We just finished with the auditors, and they were just amazed at all the charitable work that we do. So I feel blessed that God put me in this situation to be able to meet all the staff, to first to get to know the Tzu Chi organization and the great work you do internationally, and then with all the board members, with the Dr. Chair, with his lovely wife, and all the other volunteers here. It's a pleasure. I think the site visit went very well. I've been doing this, like I said, for a good 20 years. I've been several health centers, but I feel the spirit here. I feel God's spirit here. And God's definitely was helping us. So I just wanted to express my thanks to Dr. Kidd for allowing me to be part of the organization. And thank you for Tzu Chi for teaching me vegetarianism and all this. I've been eating vegetarian meal for 3 days now. I feel so much better. So thank you very much. Thank you. Hello, hi.
So John was a really integral part of us getting the designation. And as you can see here, we're officially certified from November 1st of last year. It will be through to 2022, which we renew. It's always a several year period, but we have annual certification periods as well. So that's where we are at. It's been a long journey, and I think to those that's been involved, we'll all agree that it was not an easy journey, but certainly one that I think we can look back on and be very happy as to where it brought us. And we want to see that through to additional areas of the US as well. And hopefully we'll be able to accomplish that by today's session. We hope to be able to answer a lot of your questions. We hope to be able to explain to you a lot more about what Fqac designation actually means, and be able to also share with you some of our operating nuances when it comes to our health centers. So I'm just going to ask those online to please mute yourself if you're not speaking, so that way we have less interference on the line. Now, I'm going to take a moment to introduce to you all, and I'm sure these are familiar faces, our RoundTable group. We have obviously myself as moderator, we have a great panel of our medical foundation representatives. We have Dr. K. Dr. K is currently the chairperson of the board of Medical Foundation. We have Dr. Stephen Dang. Dr. Dang is currently the CEO of the Medical Foundation. And we also have Dr. Julie Lam. Dr. Lam currently is our Chief Medical Officer for the Health Center. So we also have a number of guests, areas where they've been very interested in potentially looking at having health centers in the region. Please join me also to welcome Dr. Kenny Liao. We have Chong Shea Sibo and also Minjing Sibo as well. So CEOs of their respective regions, and certainly very happy to welcome everyone. So our panelists, please do turn on your camera. I think our group here, media team here would show everybody as a panel, so that way we can see everyone.
Hello, everyone.
Thank you.
Hello, so, Leo from New York. Thank you.
Hi there. Hi, thank you. Thank you all for joining us. We have a first question that was posed and sent to me earlier, which is, what really is an Fqac? You know, even though what I've just said, it's still sometimes puzzling, but let's invite Dr. K to tell us in more easier to understand way as to what really is an Fqac and what it means to be one. Dr. K?
I feel very grateful. Kevin gave a general pictures of Fqhc. Basically, what is Fqhc? It has to be a community-based healthcare providers. And also, it should receive funds from HRSA Health Center program, and also provide primary care service in underserved areas. People may ask, what is HRSA? HRSA means Health Resources and Service Administration. Okay. That's the answer.
Perfect. Thank you, Dr. K. And I think that's a great answer. Actually, I never really thought about sharing about what HRSA stands for, but that's exactly it. That is exactly it. We're here to deliver services to the local community. And especially in the communities that we work and potentially even live in. I know when we talk about providing care sort of locally, we have family in those areas too, and delivering good healthcare really does mean a lot. And I know we even have our physicians, choosing to be physicians because, they want to improve the healthcare in their own communities. So it is more than just being a health center. It's also the physicians that we have in the health centers ourselves. So the next question that I have received as well in advance was, what are the benefits of being Fqhc? We talked a lot about serving the community. We talked a lot about what it means to be an Fqhc and what it stands for. What is it in there that it is beneficial to actually be in a health center? Dr. Deng, would you like to take that question for us?
Sure. Good morning and good evening or good night from Taiwan. I'm currently in Taiwan. The benefits of being an Fqac, probably most people will look at it in short, will be able to get funding from the federal level. So Kevin has already shared some of the benefits. But from a health center perspective, after all, Fqac is a health center. It's a federal qualified health center. The most benefit is actually allowing us to provide better services for the community. And it's not just community by itself, but we are also targeting a very specific group, and that is the very underprivileged or low income level population, and which was explained earlier with the sliding scale. So utilizing this sliding scale, it allowed us to focus on truly the needed population. So Master has always taught us 借力使力, so I will translate it as ride along with the waves. So because we have been serving these population, and now we are able to obtain the extra or additional benefits, or even more clearly, financial benefits from federal, so certainly that would be a most direct benefit. But being a physician, I think the true benefit is for the fact that to be a federal qualified health center, we have to provide much better and more well-rounded services for all our patients, and which is indeed something that we were not able to do running the free clinic, for example. And looking back at the history, I kind of see the similar pattern. Remember how Master started it out with a free clinic in Hualien, 在仁爱街, the very first clinic, which she did share with us as well during this TIMA convention, and how we end up having a hospital. It is for the fact that she realized running a free clinic is not providing enough benefits, and now the benefits is for the patients, not for being an Fqac, for the patients. And she therefore led us to build a hospital in Hualien. So similarly, I think in the United States is that we have been running a free clinic for so long, and I think becoming an Fqac is one step more, because we are now able to do more as an outpatient. We are not a hospital. Maybe in the future, that's one of the things that our board would like us to work on. But for the time being, we do what we can as a health center. And so benefits is numerous, but what I've just shared with you all are simple ways of knowing and understanding why we are working and now a Fqac lookalike.
Great. Thank you, Dr. Dang. I think,
Kevin?
yes, Dr. K, would you like to add something?
Yes, I would like to add on something. Before I add on something, because there are a few guests in the panel, in the roundtable, so maybe we should ask our guests raise the question. And what I would like to add is Fqac financially have a lot of benefit. It is a enhanced Medicare and Medicaid reimbursement, which is called PPS, Prospective Payment System Reimbursement for Medicaid patient. In California, we call Medi-Cal, and also cost-based reimbursement for services and to Medi-Cal patient. For 65 above patient. So financially it's good for health center. And also we can apply grant from federal. Thank you.
Thank you, Dr. K. Yeah, certainly the financial benefits of us being able to further our mission, like Dr. Dan mentioned, is an important reason as to why being a health center could be a good choice, whether it is for your regions or for just being able to reach out to the low-income population even better. So those are major differences. And before we were designated to see Medi-Cal patients, our proceeds would be a fraction of what we receive now. Certainly, you're looking at about several multiples more. And that allows us to build up a practice, allows us to hire good people to join us. So those are things that really would help the overall operations of health center. I see that Dr. Liao, you have a question, Dr. Liao. Please go ahead.
Yes. Good morning, good evening, good night to everyone online. This is Dr. Liao, the Director of Medical Development and the Head of the Medical Committee from the New York chapter. This is going to be a preempt question as I'm going to ask the question later, but let me ask at this point, I think it's pertinent. So this is a collective question from many of the areas and branches of the TIMA that I spoke to. So being that said, the benefits of being an Fqhc. So what are the actual extended benefits of being an Fqhc to the rest of the regions, chapters in the United States? For example, in New York, we are trying to, and in the process of hopefully in December, to set up a Tzu Chi New York community health clinic in New York, and hopefully in the near future, when the affinity is right, that we'll be able to branch or be licensed to have the extended Fqhc, hopefully in 2 years or so, to the New York or the other areas. So my question is, what are the extended benefits and how the rest of the regions can benefit? And also, my last question was, what are the logistics of, I know this is a premature question, of being able to be qualified as part of the Fqhc branch or license to do practice in other regions of the United States? Thank you.
Thank you, Dr. Liao. Thank you for your question. I think as a health center and being able to have taken those 3.5 years to get the designation certainly should help us expand into other regions as well. And for this particular question, why don't we ask Dr. K to start, and then maybe Dr. Dan can add to that as well. Dr. K.
Yes, it's a very important question. A lot of Tzu Chi people in other areas, in other states, all have this kind of question. First, being a Fqhc lookalike right now, because we have been passing through the process, so we know about the logistic, how to apply, and also the process of application. So that's the benefit. And also, we have a team in California, which it's also a good benefit for us to move forward in other areas. Although we still need outside consultant to help. That's second benefit. But in local side, like in New York, or Chicago, or Northern California, you need to have people in place and also budget ready to run. That's my advice. Thank you.
Thank you, Dr. K. Dr. Dan, would you like to add something to that as well?
Sure. Benefits is numerous, but I think it's generally put is that having a health center in various regions, just like as what we have now in Southern California, always provides a very strong, call it a root of our medical mission. And we do medical missions nationwide. And for those areas that are able to have a health center in place, certainly will be able to assist in the medical operations or in our medical mission. The health center allowed us to raise, as I mentioned earlier, allow us to be able to do a lot more for our patients. There's only so much we can do when we do medical outreach. There are always going to be cases that can potentially refer back to our clinic for additional services. And that is something that we will be able to do. Staffing-wise, having a health center also means we have strong providers available so that in any medical missions, if we need extra providers to help out, certainly the medical foundation can assist that as well. So with a TIMA operation, or almost any type of TIMA operation, we will be able to provide some assistance. And I think to have Fqac in various regions certainly is one of the future goals that we are trying to do. And we are more than happy to see it happen. So there's a lot more, but I think overall is to be able to raise our ability to serve in all the areas that have a health center.
Thank you, Dr. Deng. Thank you, Dr. K. I think certainly with the amount of inquiries we've gotten, especially after we've received designation, it has been very interesting because we were able to sort of see a little bit as to where the interests are coming from. And we're pretty excited that, the road is sort of being paved as we speak to really build this potential medical mission across the whole country. So thank you, Dr. Liao, for your question. Dr. Liao, I see you're unmuted. Do you have a follow-up question to that?
Yes, if I may, then I want to give the question to the rest of the guests. My second question is, the Fqac, the way that I know Fqac look like, is basically set up to serve the underserved, meaning the documented and the underinsured population. As our master tells us that we have to help people who are really in need. Those are the population pocket that are either undocumented or uninsured, which is what we have a lot in the New York, I'm sure in other regions of the United States too. So how would that work hand in hand with the Fqac? Would that be a conflict, or are we underserving those pockets, the undocumented and the uninsured pocket of population? How do we strike a balance between the Fqac? We have a lot to learn, especially we are taking the baby steps. Like Dr. Dan mentioned, actually New York is only like the free clinic we are starting now, other than we have the 2 mobile vans, the mobile dental units, thanks to the Tzu Chi Medical Foundation and Dr. Ger's effort to provide us those 2 services. So we really like to see how we can be able to learn from your 10 years of experiences in California, so that we'll be able to take a quick step in establishing what we would like to be one day, aspire to be Fqac in California. Thank you very much.
Thank you, Dr. Liao. I think your question is spot on, and we do get that question a lot because I think the best way to put it is being a health center, a federal qualified health center lookalike, it doesn't deter us from serving those that cannot afford either sliding fee scale, they don't have Medicaid programs. We continue to see them. I think that's the beauty of having the designation, is that it gives us even more bandwidth to be able to serve those communities. Without, the federal subsidies, for example, a large portion of the patients that we see right now will be actually out of pocket for many of them. And with the subsidy, it gives us the ability to have the financial means as well to serve the population that otherwise we may not be able to. And I think Dr. Deng actually put it really well. A lot of times government regulations are there to prevent people from overcharging. But Tzu Chi, as Tzu Chi, we find a way to not have to charge. I think that's actually put really, really beautifully. And that's exactly what we are doing. And for those that come that can't, that they're uninsured, that can't afford to pay for care, we still see them. And in fact, there are a lot of cases that we waive their fees in order for us to deliver that healthcare. And since I just quoted Dr. Deng, Dr. Deng, would you like to add something to that?
Sure. Short answer would be it does not prevent us from seeing our targets for Tzu Chi medical mission. So anyone that has a low income or uninsured certainly are our targets. Being an Fqac, the benefit, one direct benefit is that we are able to get government subsidies when we see the low-income patients that has Medi-Cal. In New York would be called Medicaid. And, so that is a direct benefit, but it does not take us away from what we have been doing. Now, I think the to acting as or function as a free clinic, I believe I mentioned it already earlier, is that we can only do so much. And I think that is the key. We weren't able to do as much as we are doing now. So even for uninsured patients that comes into our clinic, they in the past, if they're not able to afford, we would only do say basic services. But now these basic services has been expanded to quite greatly, I would say, so that all these uninsured patients receive additional benefits. So under or looking at the clinic operation, we will be spending a lot more on each visits because they're not able to pay. But this area has already been calculated and will become a part of the reimbursements because we're getting a whole lot more for the Medi-Cal patients that otherwise would only pay us, say, a fraction, to be more exact, only less than 10% of what we would be able to get. So this extra, quote unquote, is actually anticipated and allow us, the clinic, to be able to serve these uninsured or low-income population.
Okay. Thank you, Dr. Deng. So in the whole program, I think the intention is not for us to see less of a patient population, but being able to deliver more, especially to those that are lower income. So that certainly would not preclude anybody that's undocumented or uninsured. So hope that answered your question, Dr. Liu.
Yeah, and I'd like
Dr.
to add one more thing, sorry. I think Dr. Liao was asking. So we don't know exactly what the numbers would be, but we do estimate and also try to borrow experience from other existing Fqacs. So what are the percentage, I'll put it that way, of patients type of patients that we will be seeing? We are currently looking at maybe 70% Medi-Cal or Medicaid patients and 30% cash pay. This is kind of a general idea. Is that going to be a good number so that our clinic can operate? As being able to sustain our clinic operation is also a key issue why we wanted to become an Fqac. So we don't have the exact number, but right now we are shooting at 70% Medi-Cal patients and then 30% cash. That's kind of the overall idea. Thank you.
Thank you very much, Dr. Deng. And I hope we answered your question there, Dr. Liao. Thank you very much for your questions. I see that Brother Minjing has some questions as well. I see that you were raising your hand. So I would like to give the floor to you if you would like to ask a few questions.
Thank you. I just want to take along the discussion that was talking about the target population. So can the health center accept the private insurance patients?
Absolutely. Thank you for the question. Absolutely, yes, we can. And I think, like I said, it doesn't really preclude us from seeing patients that have private insurance, that's got Medicare. It's really meant for us to be able to deliver more healthcare services, if anything. And I think Dr. Deng, you wanted to add something as well. I saw that you unmuted yourself.
Well, now you answered it already. One of the general rule of being an Fqac is that we do not refuse anyone that comes into our clinic. Certainly there are so many to see, and there's only so much we can do. Therefore, we do need to prioritize, put in a priority or some kind of a list on who are our primary targets. And the ones that we have been talking about, the underserved, uninsured, low-income patients are our primary targets. And some of them may end up to be having Medi-Cal or Medicaid, and these are target patients determined by the federal or the government. So government has already done the screening for us because these are truly the low-income population, and therefore they have become our primary targets. Commercial patients becomes a little bit more challenging because there are people that are making a decent income and they can get commercial versus somebody who is barely making enough and they are fortunate enough to get some commercial insurance, say Obamacare. Some of them may not be able to get decent services, to be honest with you, because not all insurance do have good coverage. And these are certainly also our targets. And how do we, let's say, save money for them? And that is because of the sliding scale. So for the fact that if they have commercial insurance and they are not making so much, they also qualified with this sliding scale. So sliding scale is a way allowing us to truly target and so that we don't overcharge. And I think Kevin has mentioned earlier in our Tzu Chi's culture, we kind of don't really need that because we are already undercharging and we have the habit of undercharging. And we have been doing so for so many years, even without charging. Fqac does not like to see us that we charge zero, speaking. But truly, for those that cannot afford to pay, we would just kind of provide our services, and we don't stop them from seeing us just because they cannot afford to pay. So generally speaking, we will cover everyone that comes into our clinic.
Great, thank you, Dr. Dang. And I think, just Brother Meiji, just to put a little bit more perspective on your question, I think I want to ask Dr. Lam to share a little bit as well, because Dr. Lam joined us earlier this year from another health center, and she has a good panel of Medi-Cal patients along with other patients as well. I want to ask Dr. Lam to give us a bit of her perspective as to the different types of patients that she's been seeing, especially in the sort of underprivileged areas as well as commercial as well. Dr. Dang, Dr. Lam sees the most patients in our clinic, so I think I would definitely like to invite Dr. Lam to please share your perspective as well. Dr. Lam?
Hi, everyone. So basically, as Dr. Dang and Kevin has already mentioned, we do take all kinds of patients. And one of the unique things about Tzu Chi is the way we started in terms of, a free clinic and then later a community clinic. So the patients that we're concerned about that might be uninsured or undocumented, we are already taking care of them. Now, I've come from two other Fqhcs, one actually very large, and those centers usually target Medicaid patients. And a lot of times our Medicaid patients are also, even though they are documented probably and have insurance, they aren't able to really access the care that they need. Now, even though there are other Fqhcs in the area, the location where our clinics are, we actually serve a lot of the Asian or Chinese speaking population. And I know, for example, I worked at one of the largest Fqhcs in Southern California, and I would have some Chinese speaking patients come in and they are able to get through the entire clinic without being able to speak to anyone in Chinese. And these patients don't speak any English, and some of them, can barely understand any more than like a hi or a thank you. So for us at Tzu Chi, being, designated as an Fqhc lookalike and allowing us to care for these patients as well, we are able to capture people who might not be undocumented, but actually have a strong need for culturally, competent care, and really being able to access, the call center or front desk or back office staff who can actually communicate with them. So I think it's a combination of everything. And then of course, everything else is still fairly similar. Like we will see you if you have no insurance, we will see you if you have the best commercial insurance, we will see everyone in between. But our target and what the federal government would like us to do is focus on the patients who do have Medicaid and have trouble accessing quality care.
Thank you, Dr. Lam. I think Dr. Lam brought up a really good point in the sense that, in terms of delivering the care that we're looking to deliver, a lot of times it's more than just sort of the group of patients that would just see us, but the kind of availability we have in the services that we provide in different languages. So I think, what I mentioned earlier in one of my slides, in terms of the ethnic breakdowns, that is also important to consider in terms of evaluating needs in your particular area. Brother Minji, did that answer your question?
Oh yeah, thank you. Thanks a lot. Yeah.
Thank you. So I see that we have a number of other questions as well. I'm just going to go to them. In terms of, we have Brother Jonathan asking, in terms of multi-specialty services, do we refer in-house or outside to specialists? That's actually a really good question. As part of our application for to become designated, we needed to submit something called Form 5A. And what that form actually has is a list of services that we can provide in-house. It's a list of services that we have to refer out, and a list of services that we contract. So those are areas that we need to very clearly state to HRSA. And one of the things that they discourage is basically having specialization in just one area. That's something that they don't want to see. They want to see us being able to see as many patients in our community as possible through the whole bunch of different types of services. And in fact, we know of other health centers that's tried to go for a designation, but they're specialized in just one area. And unfortunately, they weren't able to obtain that kind of designation. So being diversified just enough is important. So in our health centers right now, we currently offer medical, we offer dental, vision, as well as acupuncture services. And within those, we have certain treatments that we take care of in-house instead of just referring everybody out. Now, of course, there's services that we need to rely on others as well. But I think, it's a good example to have general primary care being the forefront as opposed to one particular specialization only. And with that, Dr. K, would you like to share a few things? I know you looked into the market pretty substantially before we even prepared. So would you like to share a few words?
Yes, actually, it's all depend on what are the patients you're seeing. For instance, right now, because a lot of patients need vision care, so we can hire optometrists to provide vision care. And if we see a lot of chronic pain patients, we can hire either physical therapists or acupuncturists to do acupuncture therapy. So if we have more diabetes, then we may consider to hire an endocrinologist and do not refer out. So for multi-specialty care, most of the time we are going to refer out instead of stay in, unless we have a lot of patients need this kind of service, we can provide in-house. That's my thinking. Thank you.
Thank you, Dr. K. I think that's exactly it. And when we talked about the patient population breakdown earlier as part of our application, you really get a sense as to what the needs are in your local community. And where we are right now, there's when I showed earlier about smoking, obesity, talking about heart diseases, those are areas that you can tell they're elevated in the areas that we serve compared to the averages of the county, of the state as well. So understanding your market is going to be very important to determining what kind of specialization you may want to have in-house or those that you refer out. So thank you, Dr. K. So I want to invite Brother Shay from Chicago. I know you're online as well. I haven't had a chance to ask any questions yet. So please, thank you for joining us today. Brother Shay, do you have any questions for us?
Yes. Thank you so much. I think this is a real good session. And so I understand to be a Fqhc, you got to be a health center, right? It cannot be a health center if you're just a free clinic. So I'm just wondering what to move from a free clinic to health center. What are the fundamental elements of health center, and what it takes to move from free clinic to health center?
Great, thank you, Brother Shay. I think it's a great question. I can see Dr. Day already smiling at that question. So I think there's obviously a lot of transition, and I think right now we're still working out that transition. A lot of that has to do with our patient population, the ones that's been seeing us for a long time, how that evolves, like Dr. Dan said earlier, as well as the overall structure. I think a lot of that requires pre-planning, to say the very least. So why don't we start in more of a chronological order here. I'll ask Dr. K to share, from 3.5 years ago when we decided what are the areas that need to change, and then we can ask Dr. Dang to share a little bit as to, the practice right now, how that's involved from a physician perspective as well. Dr. K, do you want to start us off?
Sure. I just want to raise a very important work we have done. Number one, the board need to compose of majority of health centers patients. So that's mean at least 51% of your board member need to be patients, which before we apply, we are not have a board member like that. So we have to restructure our board, inviting more patient to be board member, or we can ask our brother and sister to be our patient until at least the board need to practice more than 6 months, and with a record of every month we have board meeting. So a lot of preparation before we put the application. Thank you.
Thank you, Dr. K. Exactly, a lot of work, as you can imagine, making sure we have that representation on the board in order to even just qualify, to say the very least. Dr. Dan, what about from a provider's perspective, from a physician's perspective?
So how do we move or change from a free clinic to a community clinic? The first thought came into my mind was actually start charging. And then, but I'd say, in a way, we have already gone through that. At the very beginning, our Alhambra clinic has been a free clinic for many years. And if we look at the history and learn from it, what we have found out is that operating a free clinic, you are actually preventing to provide services for some patients. For example, earlier we were talking about commercial patients, right? So if somebody that has a commercial insurance and walk into our free clinic in the past, we probably will say, please go see your primary care doctor. That's what a free clinic would have operated. And go a step further, a Medi-Cal or a Medicaid patient that walking into our free clinic in the past, we would recommend that they go to their primary care doctor once again, instead of providing services. And all that would have been changed once we start changing ourselves or convert it into a community clinic. And I remember this is one of the major reasons why we started operating as a community clinic, especially at the beginning of Obamacare. A lot of patients, due to Obamacare Act, they were able to obtain health insurance. Unfortunately, the type of insurance they have, once they have it, they are having trouble finding a good primary care doctor. So they continue to come back to us. So to run a community clinic in a way, one of the definition I would guess that we can say is that we are starting or able to see patients with insurance, and pretty much we're working toward the goal that anybody that needs our services can come and get the services with us. That's kind of the idea. So it's to some degree, it is just a title, a free clinic versus community clinic, even though there are more specific operations tied to it. But generally speaking, Fqac or a health center has to be evolved from a community clinic. And as I mentioned earlier, HRSA does not wish us to see patients for free. That is actually one of the rules that they have set. So if you look at our sliding scale, even with the lowest income, 100% or less of the poverty level, federal poverty level, it is not zero. It doesn't mean if they don't make or they make very little and we would see them for free. HRSA does not wish us to do that. So we end up putting a charge of $20. And we kind of look at our nearby local Fqacs and we come up with this number, which is pretty low. But then in reality, when patients have come in and they don't have that $20, and we will see them for free. So we are not going to stop providing services just because they are not able to pay the $20 minimum fee. On the other hand, if we were to operate as a free clinic, yes, we will see somebody that don't have insurance, but we will probably turn away more people that do have insurance. And we know for the fact that they are not able to find a good PCP. So I think that's another way of looking at the differences between free clinic and community clinic.
Okay. Thank you, Dr. Deng. Thank you, Dr. K. And I think, aside from that alone as well, in terms of the evolution, if you would, it's the shifting population. And I think in the past, from our Tzu Chi community clinic experience, we accumulated a lot of adult population. And one of the things that HRSA actually wants us to do is see everybody from birth. It's sort of from cradle to grave, right? So you see the whole life cycle. So it's not limited to just adults or kids. It's the whole spectrum. That's what they want to deliver, or us to deliver care. And I know there was one question in terms of pediatric populations. Absolutely. We have physicians, PAs on staff that will see kids as well. That's an area that we're going to develop with a major focus. So absolutely, we will see patient populations that are not just adults. So Brother Shea, I think you have another question as well.
No. I think this is a good information for me to make decision for what is the next step in our medical mission here. Thank you.
Perfect. Thank you. And one thing to just add to that is, obviously to utilizing our designation. What would happen is that the different areas would be, or the new clinics would be counted as satellite clinics to where we are. And there's some specific nuances to that, which really is in the governance structure, how we're able to extend the quality assurance, compliance programs to the new clinics. So those will be important areas to look into as you plan out. So hopefully that helps you. one of the questions that we have as from our audience, I think this is a good question, especially, we're talking about a lot of, we're in the TIMA forum. So obviously we have a lot of great physicians that are volunteer professionals. And the question here is, in terms of accepting private insurance, I know we spent a lot of time talking about reimbursements and insurances. How does that conflict with our volunteer professionals? They're volunteering with us. We're billing insurance. How does that influence anything, if anything at all? And is that really a conflict? Is that something that really affects what we do? And I know we have volunteer professionals. We love their help here. Without them, I don't think we would have gotten this far. But it really comes down to target population too, right? I think Dr. Dan earlier mentioned that our target population is not specific those that are private insurance, but certainly we don't refuse them. But I think the specific question that I have received here is how do we strike a balance between all the volunteers that we have that still wants to come in and see patients and help Tzu Chi as a whole versus the practice that we're now billing even private insurance and amongst other insurance. So, Dr. Dan, I know you gave us a bit of a breakdown on the insurance already, and you came to us as a volunteer to start with too. How do you think that would affect the overall, and especially from your perspective?
Our Tzu Chi medical mission, which will include TIMA and the free clinic or community clinic that we are operating now, is to invite as many providers that are willing to be part of us as possible. However, being an Fqac, we do have another set of regulations from the federal level to comply. So it will make a volunteer doctor to work at a clinic with a little bit, some degrees of challenges or difficulties because there are a set of qualifications that are being set. Well, I shouldn't use the word qualification. They would have to make sure that all the providers fits, and so they have to go over. There's a lot of missing the word here. I guess it's getting late. But the idea is it will make a volunteering doctor more difficult to work at a clinic, just because it's quite tedious. And I remember back in the times when we were trying to recruit providers just to work with TIMA. So we have this TIMA application form. And it has been the longest issue for us to discuss that, shall we ask a provider to fill out I believe a 9-page application form versus a simplified 1 page or 3 pages, and even that some providers will say no. Now, and that is just a small example of having a provider who are willing to volunteer with Tzu Chi, and if you ask them to fill out 9 pages of application form, that may turn some people away. Now imagine try to work at a clinic. It's not just the 9 pages, it's more like 9 books. We have to really dig into the provider's background and make sure that what her side is asking are all answered. And some of these cannot be done by us. It has to be done by a third party. So, so that would prevent some obstacles having providers. Now, assuming a volunteering provider is very, very interested in working in our clinic and is willing to go through the whole process, by all means, that provider is more than welcome. A volunteer versus a paid staff, the only difference is paid, right? We have a lot of Tzu Chi volunteers that work in Tzu Chi and they do not get paid. Most of our volunteers are like that. So, they are staff, but they are just the unpaid staff. And I think there's a terminology for that too. I just forgot what it is, but it's the same idea. So having an Fqac does not say no to volunteer providers, but it does make it a little bit more difficult for a volunteer. They really, really have to wish to be part of us to join. It doesn't mean that they have to be paid in order to work in our clinic.
Thank you, Dr. Dan. I think that's absolutely true in the sense that we need to keep to a standard of healthcare practice, and being available to see patients on a consistent basis is important. That's why sometimes HRSA even mandates certain positions to be paid staff as well. So I think those are areas that really are reflected in that. And when we talk about the quality measures, I mentioned earlier in terms of the population that we serve, what kind of problems or chronic illnesses plague the areas that we're in. The quality, we call it CQI, which is continuous quality improvement, is a very important cornerstone of the health centers. And we're essentially measured on them by HRSA on an annual basis. So month to month, we have specific metrics that we focus on to ensure that the clinic is doing what it needs to do. Because it's such an important program, our Dr. Dang himself is involved, and obviously Dr. Lam being our Chief Medical Officer. And, I think it would be a good idea to give everybody just a couple minutes to understand a little bit as to what that quality CQI really entails. Dr. Lam, would you be able to, I know you oversee that program, you have meetings every month on that. Can you give us just a brief overview as to, the measures we're looking at, maybe a couple of examples as to why that's important, especially when it relates to the kind of healthcare that we're delivering here?
First off, I'd like to let Dr. Dang know, I think you were looking for privileging and credentialing. I'm not sure if that was what you were trying to...
thank you. It's getting really late here now.
So yeah, I think with any volunteers coming in, they do need to be fully credentialed, and there's a process that we go through that is more tedious because we have to verify that your license obviously is still active, where you might have certifications where needed, and so that's what he's talking about. So in terms of the clinical quality improvement, so basically HRSA looks at how we perform, and we cannot be performing like a free or community clinic where we do as we wish and we do our best and then hope for the best, and that's it. We are it. We are the primary care physicians for these patients. We take care of all of their needs, and we make sure that the quality of care they receive from us is not only at par with what all other private clinics and local community clinics and centers are doing, but we go above that and hopefully beyond that. So if you come into our clinics and we provide you care, it's not going to be of a lower quality. If anything, it would be of a greater quality than you would be able to expect from a private practice. For example, if you are a female coming in, age 51, then you would expect that we would ask you about all your immunizations to make sure they are up to date, see if you've had your age-appropriate cancer screening, and in that case would include colorectal cancer screening, breast cancer screening, cervical cancer screening. And we ask you, we figure out, if you might be depressed or not, if you're smoking, and counsel you on cessation. If you had any cardiovascular disease, we would address that to make sure you're on your statins. If you have any ischemic vascular disease, we make sure you have some type of antiplatelet agent on board. So we follow all the evidence-based medicine and guidelines that are set forth for us, so that it makes it where when you come into our medical center or our health centers, it's not optional that I provide you, top quality care and meet all these measures. It's required, and it's a requirement that we are judged on. And as Kevin mentioned, every month we go through all of the measures and we see how we are doing, and we choose a measure that we focus on, and we see how are we doing, how did we do before, how are we doing now, how do we reach our targets, and if we are already at our target, how do we stay there, and how do we go beyond that? So I think when we focus on all of that, we are no longer thinking of ourselves as, the free clinic or the outreach style physicians who just go out and, we just try to do our best for you and hope for the best. We really own the care of all of our patients, insured, uninsured, uninsured, all the way to the best commercial insurance, basically. And specifically, our focus is, of course, the Medicaid population, who, if they go to a private practice, probably won't be able to receive that level of attention due to the traditionally very low reimbursements at other facilities that are not Fqhcs.
Great, thank you, Dr. Lam. And I think one of the key here is that being a designated health center, especially the spectrum of services that we offer, it actually fosters teamwork. Because the departments actually have to work together to deliver that comprehensive care. So if there is a matter which is being seen by our Western medicine physicians, and there's a need to involve acupuncture, for example, to treat, let's say, pain, and also vision care as well. So the whole team needs to actually work together to make this really happen and deliver the best experience for our patients. So it's a lot more than just individuals being able to perform at their best, but it's a whole team effort to deliver that whole healthcare experience to our patients. So it'll be important to have the right physicians, and it'll be important to build up the services that you currently offer or are looking to offer in the clinics. So I see Brother Cheaton has his hand up for some time now. Would you like to ask us a question?
Yeah, thank you, Kevin. I do have a few questions or maybe a comment. I think first one is about the mobile clinic, or I would say the extension of Fqhc as a mobile clinic. So a couple of weeks ago, a few of us went to San Jose downtown to visit a kind of shelter site that providing the meal to the low income or homeless folks there. And then we also visit one of the Medivan on site, which is coming from Gardner Health Center locally here. So what they are providing, just providing a on-site Medicare service to the homeless folks. People has a wound or sometimes even have a prescription there. But they only serve like a few, like 4 or 5 people a day in a few hours there. So it's very few turn rate. And then they do require people vaccination. If they don't vaccinate, then they will go. They will not let them allow enter the van, but they will serve them outside. So viewing I think Brother Kevin mentioned that a couple of weeks ago, we do have our mobile clinic as our Fqhc extension. So when you look at that clinic, the mobile clinic, what is the focus? Is that the same focus as, or we need to have certain percentage of Medicare patients in that particular remote site that we are going to serve, or we don't see that. We purely look at the need or the necessity or the population or target population that was really needed. We just go ahead to serve, sort of like as a free service type of thinking. So that's the question. Yeah.
Thank you. I think the mobile program is very interesting, and from what we see at least in Southern California, is that the mobile program is really an extension of our clinics. So we offer the same service that we offer in our clinics, but on mobile, on wheels. And that's, I think, one of the most attractive areas. I want to sort of give a bit of a perhaps clarification on the sense that, yes, even though there are certain target population that, with the designation we want to see, it doesn't preclude us from being able to waive certain fees if they can't afford it. And we have been, especially in areas that we know maybe they're undocumented, maybe there are areas that are migrant workers, for example. Those are all things that we can continue to do. And I think the mobile, what it helps us is to reach areas where our clinics can't, or they can't get to our clinics. I think that really fits into the Tzu Chi medical mission, right? And Master said, you know, for those that can come out, we want to be able to walk in to see them. And that's what we are with the mobile clinics. And I'm certainly really happy to hear that you're providing care to those shelters, etc. And I think we are going to aim to continue to do all that work because it is very meaningful work. It doesn't, just because we're designated and the Southern California mobile are in scope, doesn't stop us from taking care of patients in those areas. In fact, I think there's a lot we can do for them, whether that is through mobile or not. So those are things that I think we will continue to do, and if not even expand more sometimes on those as well. Dr. K, I know you were smiling earlier on that as well. Do you have, would you like to add to that?
Yeah, actually, you pretty much cover almost everything. One thing I just want to raise is currently we are collaborating with Pacific Clinic. So we extend our vision service and later dental service, maybe medical service to those areas. The main target certainly is medical patient, but we are not excluding other patients, especially undocumented patient. Thank you.
Thank you, Dr. K. Yes, absolutely. We would encourage to, even more of those activities, in fact, because I think under the same umbrella, it would really help, reach those patients that are otherwise harder to reach and those that can't come. So, Brother Shijian, did that answer your question?
Yes, thank you. Thank you. Yeah.
Thank you. Thank you for your question. We have a number of questions here as well pertaining to how, medical foundation here being and having Fqhc lookalike clinics in Southern California as well as on mobile will help other regions pioneer their way or accessible to having those health centers as well. I know we've had a number of meetings with different regions, but in general, how does that help in terms of our experience, in terms of how they can potentially start exploring these ways? I'm just going to throw this question out there for our panelists to answer, because it seems like there has been a lot of interest, and people are actually wanting more information as to what would be the first step that they should take.
I will start.
Okay.
Answering some of these. It's a more of a general answer. It really depends on what the regions would like to focus upon. So if we were focusing upon a medical mission style that we are very familiar with, having our TIMA team running it, then there is no need. But on the other hand, if we were trying to do what Fqac is working, then that's a different story. So we have already spent a lot of time looking at the details of what Fqac operation is like. So that pretty much will be the baseline of what the region is, to see if any region is interested in having such operation. So if you wish to do all the measures amount or the patients that walk in to a Fqac, then by all means, that would be a good reason to have a Fqac satellite run in a different region. So medical foundation, we are acting like a seed. We already have a seed planted in Southern Cal. So all the other regions who wish to have a and another or new Fqac, they will work as a satellite because it will be a lot easier to obtain. Having a seed already, certainly we can discuss and see how that goes. So the way I like to answer these type of questions would be, we are changing, and we are changing only because we do not want to change. I don't remember the exact year, but we actually had a TIMA convention, and that was exactly the title, to change or not to change. In the early 20, I think it's like 13 or 14, something like that. But in any event, we are changing, but that's because we do not want to change. Our Tzu Chi medical mission are still there. So a related example or question earlier was regarding the mobile. So the mobile can still see a very selected target, say the homeless group. And that indeed, it is Tzu Chi's mission. And the mobile was created to be able to serve them because they are a group of patients that cannot come to our clinic. But on the other hand, if you will try to look at it from an Fqac, that may not be the number one targets because in a way, Fqac is a health center. So it is fixed. It does not go to the patients. And if we were trying to operate it under Fqac, then all the measures that are part of the Fqac, that is something that we need to apply to all these homeless patients. Then the next question is, are we able to do all these cancer screenings on them, for example? And the answer could have been no. It's not easy because they are homeless group. So what does that mean? That means we are keeping our Tzu Chi mission, namely a mobile can go out there and serve this population, but that may not necessarily be part of the Fqac operation. And I think that is something that we can look at. So I like to summarize it in terms of our operation would be one major part, Fqac, but on the other side, we just call it Tzu Chi mission or medical mission. And that way, it will keep things much clearer. And that will, each different targets can fall under these two major categories.
Great, thank you. Thank you, Dr. Dang. In terms, you treaded and onto a point which I think we're going to get to in a second here, which is sort of the expansion across U.S., not only in the U.S., but certainly across California as well, representing opportunities. We talked a bit about sort of the insurance breakdown, and what we can say from our previous experience is that as a community clinic, as a free clinic before that, we had a number of differences. I think Dr. Dang made a really good point earlier in that, we're not trying to discourage people from coming to see us. What we're doing is that we're increasing the amount of population we're seeing in the target areas that health centers are meant to see. So the ratios change because of that increase, as opposed to us actively trying to discourage people in general to see. There are some population that really shouldn't be seeing us because we're not confident we can either deliver the best care to them, or that they really should be going to the areas where they should be they could be looked after better. So those would be populations that we would I wouldn't say turn away, but certainly encourage them to go back and see their PCPs. Especially if we're not. So those are things that we actively take, and that goes into a topic of, how do we maintain compliance? And compliance really comes in a lot of different ways. I know there are questions about that in our chat here. It takes form in not only in terms of operations, in terms of quality assurance, like Dr. Lam alluded to earlier, but it included a lot of different areas, different areas, such as how we process, how we, even look at bidding for different capital spends, how we manage expenses, sign-offs, all of those are part of compliance as opposed to just clinical ops. And so, it's still a learning process for us, but we're glad to, have a good team to be willing to learn and have good consultants as well to guide us through. Earlier on, you also met John, who comes to us with more than 20 years of experience. Those are all different pieces of the puzzle that helps. And for those of you that will be looking at exploring health centers in your respective regions, this will be an important resource to consider, which is how would these individuals help you locally in terms of guiding you through compliance, making sure that the operations fit your local audience and the market there as well. So those are things to just keep in mind. And one of the questions here pertains to interns and shadowing. I think I would like to ask Dr. Lam to give us a bit of a color on that, because right now we do have students that shadow with us. Dr. Lam oversees our providers who have shadowing students. And Dr. Lam, would you be able to give us a little bit on that? I think obviously we have been doing that. Can we continue? What's your perspective, especially when you were evaluating to taking them on for the different physicians we have?
Actually would like to go, I'll answer that question, but I actually want to go back a little bit in terms of people's questions regarding whether they want to become an Fqhc like under our umbrella or not. I think a way to think about that is, I think the way that we've been practicing outreach in our free clinics is we provide what care we can. But I think as a health center, we have to become the clinic that we want to be a part of. So if we think about providing care to the homeless and you're thinking that's not really me, like this is just, I want to give them, do what I can outside or in whatever case, then I think the old way that we're practicing is okay because you just do your best. But I think as a health center, what I hope to see at least at Medical Foundation is we built the kind of clinic that we all want to be patients at. And we feel like we provide such great care that I want my kids to come here. I want my parents to come here. I want to be a patient here. I'm willing to be a patient here. And I think if that's the focus, I know insurance matters, but it also doesn't, because, as the CMO, it does matter because we're looking at those numbers. But as a physician, it doesn't. I just provide the best care. And I work, at UCLA. I work with LA County. I work now at Tzu Chi. The level of care should be similar. And that's what we're aiming for, that you can see me at a UCLA health center and it's the same quality and it's the same person and it's the same care that I provide as you would at, Tzu Chi Medical Foundation versus in LA County, even in the mobiles that go out. So when we go out with Pacific clinics, we're not providing inferior care. We are aiming to provide the high level quality of care. And we can even do, let's say, pap smears in our mobile clinics. Like that's what we're going for. We're a full-blown clinic and we're the clinic that we want to be patients at too, because we have that level of standard and quality. I think if other locations are looking at that or looking to become that, then this route would make sense. So that just adds a little bit like a sort of a different perspective to what Dr. Deng has mentioned. But back to your question. So interns and shadowing, yes, we can have interns or not interns specifically, let's say like students who want to shadow at our clinics, perhaps interns or residents who might want to rotate through our clinics. That is okay, but it needs to be arranged carefully. And that goes back to our volunteer physician statement as well. Anyone who comes into our clinics, who sees our patients, who works alongside with us, they do need to be, if they're a professional, privileged and credentialed. If they are not a professional, they still need to be screened. We need to make sure that they are appropriately, let's say, vaccinated, that they have reasons why they're there, that they play their specific role. So I cannot have, let's say, a volunteer who has no US credentials, but they might be a physician elsewhere, come into the clinic and provide medical care for my patients. That would not be okay because they are not licensed and held to the same standards or regulations as we have here for our licensed professionals. So with every person who might come in, they would apply and we would review their applications carefully, get a good idea of what their expectations are coming into our clinic. We let them know what our expectations are and what they are allowed and not allowed to do under the rules and regulations. And then we make a decision, and then hopefully everyone has a good experience because our expectations are met.
Great. Thank you very much, Dr. Lam. I think there are obviously a lot of great questions. We can't get to all of them, unfortunately, but hopefully this session has been helpful and useful to you. I just want to invite our panelists to give us closing remarks. Dr. K, do you want to start us off? We're just going to wrap up this session here. Do you have any closing remarks for all of us?
Yeah, I know a lot of people really want to have health center in their side, even out of California. But anything starting from zero, we need 3 powers. One is human being, manpower, and number 2 is money. And also the third one is will. You are willing, the willpower is much bigger. So if you have a willpower, you are going to make it from zero. Thank you.
Thank you, Dr. K. Dr. Deng, do you have any closing remarks for us?
Sure. I would like to close it with the same thought of what I just said. We are changing only because we don't want to change. Just don't forget what Tzu Chi medical mission is about. So becoming an Fqac is just one of the quote-unquote tools that we have chosen to use so that we can continue on our Tzu Chi medical mission. It does indeed provide a lot of great benefits. On the other hand, it will make our routine work a little bit more challenging because we are now not only wanting to perform Tzu Chi medical mission, but we also have Uncle Sam's rule to apply, right? So all the HRSA rules is something that we need to be in compliance. It will make it slightly difficult. But once again, we are changing just because we do not want to change. And just have that in mind. And we welcome any region who would like to be part of the Fqac. We can always discuss. Thank you.
Thank you, Dr. Wang. Thank you very much. Dr. Lam, do you have any closing remarks for us?
I will add on to what Dr. Deng said. So we are changing, but I think it's good despite the regulations and some of the stress that goes along with it. We will be held to very high stringent standards, allowing us to still do what we love, which is care for all people, but with money, as Dr. K mentioned, financial resources, and then holding us to the highest standards possible so that we can provide the best care, that we can. So thank you.
Great, thank you very much. I want to thank all of you for joining us today, and also a special thanks to go out to our special guests, Dr. Liao, Brother Shay, Brother Mingjing, for being a special guest and joining us. We certainly look forward to expanding the footprint and really taking Tzu Chi medical mission to the next level and across the entire U.S. So thank you again for joining us this morning. We hope that you find this panel very useful. If there are any questions after the fact, please feel free to forward it to our moderators, session team leaders. We try our best to work to get back to you on that. We have regional meetings with many of you as well. So if you have additional questions, we'll be more than happy to schedule a meeting specifically with a region also. So thank you very much. And please enjoy the rest of the sessions for this TIMA meeting. Thank you.
Thank you.
Thank you, everyone. Thank you.
From New York.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye-bye.